Recording in progress.
Sir, please start. We are live.
You want me to start right away?
We are start.
Sir, Professor Khilnani, sir.
Yes.
I start now, okay?
Okay, you want me to start? Hello?
Good evening.
Dr. Bhattacharya will start.
Yeah, that's what I thought.
Can I start?
Please,
Can
sir,
I
please.
start,
Start. Yeah. We are in live, sir.
Okay. Good evening, everybody. On behalf of Association of Chest Physicians West Bengal, I, Dr. Somnath Bhattacharya, General Secretary of ACP, welcome you all in this evening symposium. We all are going through the deadly second wave of COVID-19 pandemic in the last few months, which fortunately is now started to decline very gradually. However, we still are getting a large number of patients in our OPDs who have come with numerous pulmonary complications even after getting cured from COVID. Keeping in this situation in mind, topic of our today's discussion is post-COVID pulmonary complications. To moderate today's sessions, we have Dr. Raja Dhar, who needs no introduction. And our speakers today are eminent pulmonologist Professor G.C. Khilnani and our very own Dr. Shelly Shamin. Unfortunately, our moderator, Dr. Raja Dhar, will be late and you will join in a 5 or 10 minutes. In the meanwhile, may I ask Professor Khilnani to show a few interesting cases of COVID-19 diseases. So I start, Professor Khilnani, I think who needs no further introduction to us. Professor Khilnani, please.
Ladies and gentlemen, at the outset, I thank Dr. Somnath Bhattacharya and the West Bengal Chess Society and especially Dr. Raja Dhar for inviting me to talk about post-COVID pulmonary complications. As introduced by Dr. Bhattacharya, we are actually struggling with more than about 3 crore cases who have recovered from COVID. And actually, this is the official number who have been diagnosed by RT-PCR, but actual number is much larger and it is several fold. And if you ask me today, 80% of my OPD is actually post-COVID. So this is actually a panel discussion where I will just set the ball rolling by talking about few cases, because you cannot discuss pulmonary complications without discussing radiology. So I am very thankful to the moderator, Dr. Raja Dhar, who have allowed me to that. So pulmonary post-COVID lung involvement could be in the form of persistent cough. It could be exacerbation of asthma. It could be exacerbation of COPD. It could be pneumothorax and pneumomediastinum. It could be secondary infections, variety of, could be fungal, bacterial. I am not going to go into that. What dreaded complication is the pulmonary fibrosis. So I'll be showing two cases on which we'll building up our discussion. So this was a 47 years old diabetic asthmatic patient who presented with fever and breathlessness, and he had hypoxemia, he had pneumonia, his SpO2 was 77, and when we did a CT, you can see the classical picture of ground glass opacity, peripheral. Anybody can, any pulmonologist or a physician would say, oh, this is COVID. But at that time, when this case came, we were not so aware of that. This is during the almost more than a year back. So he was treated with oxygen support, with remdesivir, tocilizumab, convalescent plasma, gradually improved. A repeat RT-PCR was sent after 14 days with admission. It came out to be negative and he was discharged in tapering doses of oral steroids. But 7 days post-discharge, he presented with severe breathlessness, with ghabrat. His pulse rate was 160 with respiratory rate of 130. He had hypoxemia, SpO2 of 85%, and PO2 was 50 millimeters of mercury on room air. So when next CT was done, you can see the consolidation have increased. You can see air bronchograms. You can see some kind of interstitial thickening also, if you can appreciate that. So obviously lung condition has worsened. He had to be taken on NRBM, a repeat CT chest, as you can see. Repeat RT-PCR was positive. This is what we saw during the first phase, that patients were getting readmitted, and sometimes the PCR, after becoming negative, became positive. On third day of admission, he had sudden increase in breathlessness and tachycardia. Urgent chest X-ray was done, which showed the presence of right-sided pneumothorax, as you can see. A pigtail insertion was done for that, and strict monitoring of patient was done. Patient improved and pneumothorax got resolved, and pigtail was removed after 5 days. So this was a sort of success story. But after 6 weeks from discharge, he was on oxygen and he came with this kind of CT. And you can see gross pulmonary fibrosis, you can see interstitial thickening, which is more in the periphery. You can see a little bit of ground glassing also. This is what the pulmonologist today is worried about. And this is a very, very difficult situation. Now I show you case 2. This is a 34-year-old female working in a multinational company with no comorbidities, unmarried, but only obesity was there. On 26th April, she had fever, body ache, RT-PCR was positive. 9th day, she had hypoxemia and was admitted and put on NRBM. Received remdesivir steroid, discharged after 21 days of admission on tapering dosages of steroid. She was on oxygen. On 40th day, SpO2 was 93. She was unable to go to washroom. And this was the CT with a score of 25/25, while she was on 22nd, this is 22nd day of her illness while she was in hospital, and you can see the pneumomediastinum. Now, after that, this was the lower cuts, and you can see the air bronchogram consolidation. There is no area which is not involved. And pneumomediastinum can also be seen in this. So on 40th day, when I saw her on online consultation, her TLC was 10,600, CRP was 18, D-dimer was 2,050. The question was, of course, we continue with the tapering dosage of steroid. Should we give anticoagulation, neuro-oral anticoagulants, or aspirin? Is it time to put anti-fibrotic drugs? We were not sure. So what we did was we continued with tapering doses of steroids, and on 62nd day, she was able to go to the washroom. Till that time, she had severe proximal muscle weakness. She was requiring oxygen only for going to the washroom. She had severe fatigue. Her TLC was 12,800. D-dimer had come down to 1,230. CRP became normal, and ferritin was also normal. So I asked her to come to the OPD on 75th day of her illness. So when she came to the OPD, she was able to walk a few steps. She had proximal muscle weakness. She had SpO2 of 98% on room air. TLC was 10,200. D-dimer has further come down, and CRP was 21. 2.1. This is actually 2.1. So she was unfit for PFT. She was unfit for 6-minute walk test. So I got a CT done. And look at this CT. Almost close to normal. We didn't give her any anti-fibrotic drug. She was not on neuro-oral anticoagulants also. She was just on tapering doses of steroid. And if you compare the two CTs, this is on 16th May and this is on 10th of July. So this is how the COVID lung involvement behaves. That a score of 25/25 with pneumomediastinum, with God is with you. is almost clear, sir. The question that we'll discuss during the panel discussion is, what should we do? Should we give them steroids? Should we give them anti-fibrotic? How should we give them anticoagulants? There are not too many answers. And this was another person who is actually father of our nephrologist, and I have his permission. On 28th April, on after having COVID, and he had hypoxemia, he was on oxygen. This was a CT, and we thought he has quite a bit of pulmonary fibrosis. As you can see, he had ground glassing also. But on this is actually done today morning, and you see the clearing. We didn't give him any anti-fibrotic. We just gave him tapering dosages of steroids and followed him with CRP, D-dimer, and CBC. However, this is another case which is right now admitted, who came with hypoxemia post-COVID, and you can see a whole lot of fibrosis. And after 15 days, this is the CT, and you can see this bronchiectasis, you can see the interstitial thickening, and you can see thickening all around. And if you enlarge it, this is the classical bronchiectasis that you see in patients who have a adverse outcome. This patient is still requiring 1 liter of oxygen. You can see the bronchiectasis, you can see the interstitial thickening. Here, you can see interstitial thickening. You can actually make out lobule in this case. So therefore, this is a patient who is on nintedanib at the moment. And we'll talk about the role of nintedanib in such kind of situation, when to give, how much to give, and how long to give. There are no answers in the literature, so we'll be talking about their experience. Now I'll be showing you some radiology of some more cases which I think are relevant to our discussion. And the first one is this X-ray. This is a signature X-ray of a COVID. Peripheral consolidation that you see, more seen in the lower zone. If you see this X-ray today, this is nothing but COVID. But this is the X-ray which one would not be worried. Ground glassing opacity, peripherally, no air bronchogram, no evidence of fibrosis, no evidence of pleural effusion. And these are the patients who are, this denotes COVID inflammation, and they are likely to improve over a period of time. Now, this is the CT of a COVID patient. You can actually see a lobule here. And I thought this is interstitial thickening. There is a bit of ground glassing also, as you can see here. You can beautifully delineate the lobule actually. It is so nicely it is done. And I thought this is the patient who will go into lung fibrosis. But fortunately, all these patients with the treatment, whether with steroids or with time, they tend to improve. Now, this is organizing pneumonia, which is caused by COVID inflammation. You can see consolidation, you can see air bronchogram. I already shown you the this is not bronchiectasis. This is air bronchogram, classical organizing pneumonia, which we see in COVID also. And this is what is called pulmonary fibrosis, which is a dread complication, which I have already shown. If there's a pleural thickening which is uncommonly seen in patients with COVID, this is not a good sign. Although it's not well described, well documented, but this is our patient who had thickening all around, whether it was secondary or primary, I do not know. And finally, this is not COVID. This is classical CT of idiopathic pulmonary fibrosis. As you can see, honeycombing, no ground glassing, lower lobe involvement. As we all pulmonologists and know that this is a classical picture of why I'm showing this, that we are utilizing treatment of IPF in the form of anti-fibrotic drugs, nintedanib and pirfenidone, for treating lung fibrosis in patients with COVID fibrosis. There are no studies that I know that which has come whether it works or doesn't work. But important thing is that we should not cause any harm. We should not give anti-fibrotic drugs when not indicated, because these drugs are pretty toxic. they worsen the quality of life of the patient once you start, whether you give pirfenidone or nintedanib, should be given judiciously, and there is a basis for giving it because especially nintedanib has been given in patients who uh, who have got fibrotic ILD other than idiopathic pulmonary fibrosis. So therefore, we have utilized that knowledge and information and evidence to start treating COVID fibrosis, but till now we do not know what is right and what is wrong. So, ladies and gentlemen, I'll stop here, and I have just given you an overview of only lung involvement, especially pneumonia and fibrosis. I have not touched upon other things, and I'll give it to the Dr. Raja if he has arrived for to carry the discussion forward. Thank you very much.
Thank you, Dr. Khillani. I'm sorry I'm late. Sorry, everyone, I'm late. Thank you to ACP for hosting this meeting, and thank you to Dr. Khillani and Dr. Shelly Shamim for being here. Shelly, would you mind putting your camera on, please? Thank you. Thank you very much. So we'll start the discussion. I'll start off with Dr. Khillani. Dr. Khillani, I missed your cases thanks to the traffic in Kolkata. It's getting as bad as Delhi, at least in some ways. COVID, traffic, everything is getting similar, I guess.
I understand.
Start off with a question for you, Dr. Khillani. So this fibrosis that we talk about, the precursor of that, I guess, is healing. And any infective process, it's not something that is sort of unique to COVID. Any infective process is always healed by the means of fibrosis, by the formation of scar tissue. And I'm using these two terms interchangeably, scarring and fibrosis, maybe wrongly, that's the wrong nomenclature, but it heals by scarring. Now, India is the world capital, the global capital for TB. And there also, there's a lot of scarring, there's a lot of healing by formation of scar and often by the formation of fibrosis. So I have two questions for you. The first was, is the fibrosis or the scarring of COVID-19 any different to the infections that we've seen till date? That's the first part. And the second part, peculiar to TB, maybe relevant to the physician audience who is listening to us today. Do you think that the scarring of TB, the healing in TB, has any similarity to that what we find in patients with COVID-19, or do you think it's completely a different animal?
So I'll start second question first, which is a little easier because we have seen a lot of cases of tuberculosis as we grow as undergraduates. So TB infection basically causes destruction of the parenchyma, and sometimes you see not cavity but just spaces which are absolutely devoid of lung tissue, and it is classical. It's called cicatrization, as we understand. The scarring of tuberculosis is localized. It is it leads to, of course, compromise. It leads to shift of the mediastinum to one side. We of course know that, and histologically, it is entirely different from what we see in COVID inflammation. And if I talk about and of course, as you see radiologically, you see usually the upper zones are involved, or it could be associated with pleural fibrosis also, and there's a pull of the mediastinum towards the same side, and so on and so forth. And there's no interstitial component into that. It's simply the whole destruction of the parenchyma. Whereas COVID fibrosis is a different ball game altogether, and I have gone through the autopsy studies initially, which came from actually Italy, and they realized that the inflammation of COVID is actually they found a lot of microthrombi into that. Secondly, that it is usually diffuse, it is usually peripheral. It does not lead to any shift of the mediastinum to either side. And of course, fibrosis is fibrosis. And there are various mechanism which has been described, which I cannot recite without showing a diagram or something as to what are the mechanisms. So fibrosis is different, but the implication is same. The implication same in the sense that the parenchymal tissue is destroyed, and it leads to reduced resistance to infection besides hypoxemia. In tuberculosis, you only occasionally see hypoxemia in a very advanced stage, or when there is extensive fibrosis, you see hypoxemia. But in COVID fibrosis, the hypoxemia is actually profound. Thank you.
Sure. And Dr. Khilani, very briefly, I mean, the other lobar pneumonias, you would think the healing is similar to what we get in TB, only more complete healing. I mean, there's hardly any scar tissue left behind when someone with a pneumonia, maybe a strep pneumonia heals.
Post pneumonic scarring is usually localized to a lobe or a segment, usually.
Sure.
It depends upon what is the cause, whether it's a measles is the cause or the streptococcus pneumonia is the cause, what is the situation of the host, and what it leads to fibrosis with bronchiectasis. That is the classical thing. Now, we can keep on talking about that. Pneumonia may get necrotized, then it becomes a cavitary thing. But generally, it will lead to bronchiectasis, fibrous traction bronchiectasis with fibrosis with traction bronchiectasis, or it will heal without any residue.
Sure. So I think generally speaking, to summarize, focal disease, mainly unilobar or bilobar disease, be that in sort of lobar pneumonia or in case of TB, there will be traction bronchiectasis in TB, but they'll be very focal. And it's much more generalized in peripheral disease in patients with COVID-19, like you said. And one of the questions that I get often, and we'll sort of speak about it because I'm sure we'll get that question, would anti-fibrotics be useful in patients with post-TB fibrosis? And I guess we, like a lot of questions, we won't be able to answer that on this panel. But I guess with the nature of the fibrosis and it being more focal and localized, the chances of response would be even lesser as compared to what we have in COVID-19. I think that's probably the message from my side. And you would agree with that, Dr.
Sure.
Do you think that's sort of fair to say?
Yeah. Sure. I think we should go ahead.
Sure. So I'll go to Shelly next. Shelly, another question which has interested me is about the fibrosis in COVID being reversible. So we've always, when we have talked about fibrosis, talked about traction bronchiectasis, we have talked about that being as progressive disease. In COVID-19, there seems to be a degree of reversibility. All of us have seen these scans which even show traction bronchiectasis. And then Dr. Khilani, I think, showed a case where there was reversal. The scan became normal in spite of having very severe disease. Is that something that you've seen before? And what do you think, how would you hypothesize the reason might be for that?
Definitely, actually, in COVID, what we see is that whatever initial fibrotic change we consider in CT, like traction bronchiectasis, maybe interlobular septal thickening, or maybe subpleural bands, all these things can be reversed over time. Even traction bronchiectasis, which is somehow was considered to be a symptom of fibrotic lung disease, but in COVID we see that even those traction bronchitis gets reversed over time, because that's the experience. So that's why the radiologists are nowadays tending to say not fibrosis initially in the CT picture, they trying to consider it as fibrosis-like lesions. So they are changing their terminologies. So I think yes, there is some fibrotic activation of the fibrotic pathways. Maybe this process of fibrosis is immature initially, and immature fibroblasts are there. Collagen fibers are not mature enough, and then the fibrotic pathways gets reduced over time, and then comes the resolution path. So probably initially there is a activation of the fibrotic pathway, and maybe it is not longing enough to have a mature fibrosis, and gradually this immature fibrosis getting remodeled. So that might be the answer of this question. We really do not know why this is so, but this is the how we see.
So I think this will be a recurring theme as we go along. There's hardly any evidence in this space. So a lot of what we are saying is
Right.
our thought process rather than being based on evidence. The autopsy study that Dr. Khillani spoke about actually looked at this, and they spoke about immature fibrosis versus mature fibrosis, the fibroblast that Shelley spoke about. And I think the carry home message here is that fibrosis here, even traction bronchiectasis, did not essentially mean that the process would not reverse. I'll come to you, Dr. Khillani. Another question that often gets asked is about markers which might indicate progressive fibrosis in patients with severe COVID-19. So are there indicators, if you see a patient in the ICU on oxygen, can you tell this patient would actually progress far more as compared to someone else who might be on an equal amount of oxygen?
So, Raja, I would answer it in a different manner because we are talking about post-COVID. The people who are likely to have fibrosis, post-COVID fibrosis, are the ones who are elderly and those with comorbidities. I need not recite those comorbidities, starting from diabetes to transplant and chemotherapy. And those who have severe disease requiring ICU, those who have extensive pneumonia. This is the information we have. Now, once they become better and they are sent home, I'm answering your question in a different manner. Once they go home, and unfortunately you didn't see the case, which actually was exemplified by that sometimes they would have a CRP of 20, or they would have a D-dimer of 1500. Their oxygen requirement may not be there, maybe 1 liter or something. And then their X-ray shows some kind of shadows and they go home. How do I follow them up for fibrosis? How do I, first and foremost, as I shown the case, 2 cases I shown, I do not put them on anti-fibrotic drugs straight away. And of course, we all know that we go on a tapering dosages of steroids. But what is important is how to follow the inflammation. The inflammation I follow is by doing the blood test periodically beside the symptoms and the oxygen requirement, which is actually most important. The blood tests are CBC, CRP, D-dimer, and ferritin in that order. To my mind, out of them, CRP is most important, which gives me the evidence of inflammation. Second is D-dimer, and third is lymphocyte count, and ferritin is, in the ICU, it gives me a prognostic marker, but after that, I do not rely much on ferritin. Now, if there is a persistent elevation of CRP, then I'm worried that the ongoing inflammation is there and this person may go into fibrosis. That helps me to modulate my steroid therapy to them, and this is absolutely anecdotal based on what I am practicing, and I'm not imposing anything on anybody on that. But this is how, having followed the hundreds of cases that I have done. But actually, the fibrosis. Can I go on for 2 minutes?
Yes, please.
Actually, the assessment of fibrosis I do not do before 6 weeks after the discharge. When I call them back to the OPD, if they are fit to come to the OPD, that is the time I ask them the few questions. Do you feel short of breath? What is your oxygen saturation? Are you requiring oxygen? Are you able to walk how much? If you climb a flight of stairs, are you breathless? Can you do that? And now at that time I assess whether this patient is fit for PFT or if he is fit for 6-minute walk test. If his baseline saturation is less than 94, I do nothing. I never do a PFT or a 6-minute walk test. I straight away ask for a CT scan, no X-rays. However, if the oxygen saturation is more than 94 and the person is able to walk, then I do spirometry, a diffusion capacity for carbon monoxide, and 6-minute walk test. Now, here I don't have any cutoff points. If the vital capacity is relatively, in my experience, is a poor marker of lung fibrosis, as compared to the diffusion capacity, and I rely more on the 6-minute walk test if the person is able to perform. If there is a desaturation which is significant, more than 3, actually it is much more than 3, but 3 I take it as cutoff, and if the vital capacity low and or the diffusion capacity is impaired, then also I subject them to CT, and then I combine them all to make an assessment whether this person is having pulmonary fibrosis or no, exactly the way the case 2 that I shown, that lady with the 25 by 25 score, her lung had cleared, and the first case the lung had not cleared, and the third case which I showed of a young 40 years old male who actually went into pulmonary fibrosis and required, I wish Raja you were there to see those cases. Thank you.
So Dr. Khilani, excellent points you make. I think this is extremely important. So I'll spend another minute on this. So you said 6 weeks, look at CRP, climbing or static raise CRP.
No, we do CRP, D-dimer in between also. But
sure, that's what I'm saying. So you do linear CRPs and D-dimers, etc. But at 6 weeks, you want to bring the patient back to the clinic if the patient is capable of coming to the clinic. You would do a spirometry, a DLCO, and a 6-minute walk. You've given us very nice cutoffs for these. The only point where my practice is different, and again, I'm not trying to impose anything on others, is I would actually get an HRCT done on all patients with severe COVID-19 pneumonia, irrespective of whether they're desaturated by a certain percentage or not. And my theory is that even if you have a little bit of fibrosis, you would need to follow these patients up in the long term to look at presence of fibrosis which progresses. So I would want to take from you, Dr. Khilani, because this will be an important take-home point, and then I'll ask.
No, the thing is that, okay, let me, with your permission, can I share my slides again? And I'll be able to explain what I'm saying, because this could be important. So, sorry for going back to the. So this was a lady. Now this lady had a course of 25 over 25. She had pneumomediastinum. She required oxygen, and on 40th day she was better. Her D-dimer was coming down, and on 62nd day she was better. She was able to go to washroom. On day 75 she came to the OPD. I didn't wait to get a CT done. I straight away sent her for CT because she had a severe involvement.
Sure.
What I meant to say that not everyone would require a CT scan. Somebody might not have had a severe disease. Somebody had a score of 10 by 25. He did not require oxygen in the, he didn't even require oxygen during the admission or required minimal oxygen. And this was the CT that I saw on 75th day,
right,
without any anti-fibrotic. That is what I wanted to say. And I'm not saying that this kind of case straight away CT, no questions about it.
Sure.
But you have to individualize. Thank you.
Sure. No, thank you. Completely agreed. Shelley, if you have a quick take, anything different on that? So that was one thing. The next question I wanted to ask you, I'll put that question also now, is about steroids. So Dr. Khilani has spoken about steroids already. So your approach, maybe in the case that he showed, on a different case that you have seen, you've seen multiple cases like this. What makes you decide about long-term steroids? How long would you give those steroids for? What would be your tapering regime? And what would help you to decide how and when to stop? So those are my questions for you.
But honestly speaking, if we see the evidence, then we have to continue steroid up to 10 days. Because all of the studies that were done, including the recovery trial, they use the steroid for 10 days.
Sure. So Shelley, we are talking here, just so that we don't get the audience confused, we are not talking about COVID here. We are talking about post-COVID. So the data that you're talking about recovery was about use of steroids in...
I agree. Again, there is no trial or studies on using in post-COVID period of steroid, except few observation studies. So what we can do is that after an initial period, the second or third week, if you see the patient still hypoxic, then definitely I would consider patient recovery is not that satisfactory, then I would definitely go for CT scan. Not only CT scan, I would go for CTPA, including a HSCT card. So that will give me an insight whether there is other things, means pulmonary embolism is there or not. If not, okay, fine. Then again, from this HSCT card, we can definitely see how is the condition of the lung. Now, at the time of third week, when we usually stop the our usual regimen of steroid for initial cytokine storm, then at that period, if we see there is significant changes, even early changes of fibrosis is there, then definitely we may need to continue a low dose of steroid. That is important. I wouldn't consider to continue the same dose like whatever we use, 40 milligram twice daily or once daily of methylprednisolone or equivalent of dexamethasone. That will not be continued after 10 days. We need to reduce the dose, need to taper it up to a less than, I would say, less than 20 milligram equivalent of prednisolone or 16 milligram of methylprednisolone dose after 10 days or maybe 15 days. And then you can gradually taper it off within a period of I would say 4 weeks, or maybe if you want to extend to 6 weeks maximum. Why I am saying is that this is also my personal experience, what I do. Apart from that, there are few observational studies of use of long-term low-dose steroid in these conditions where there is early change of fibrosis, or maybe I would say significant changes even after 3 or 4 weeks. And they have used prednisolone equivalent of 26, less than 26 milligram. What I have with me in the paper says that they have used less than 26 milligram, and they taper it up over a period of 6 weeks. That means you have to use low dose, less than 20 milligram, or maybe like that, and you need to taper it up gradually over a period of 4 to 6 weeks. That should be the regimen, I think. Often I see that people are using high dose, maybe 40 milligram or more than that, for more than 15 days. That I definitely say shouldn't be done. Shouldn't be done. There will be a lot of adverse effects. Muscle myopathy will be there. There will be secondary infection. So outcome will be really bad in those conditions.
Sure. So, Shelly, tell me what makes you decide how long? So in my practice, there'll be patients who might actually go up to 3 months. Like in some patients, like you said, it might be 4 to 6 weeks. So this distinction, what do you base that on? Just clinical features, or
mostly?
Like you spoke about biochemical markers. Would you use biochemical markers? What helps you decide?
A combination of them. Definitely combination of them. CRP, I think, is the most important biomarkers that we should follow. Not only it helps us to assess the regression of the inflammation, but also it helps us to assess if there is sudden rise of CRP. We have to think of secondary infection also. So that's why CRP should be monitored. And again, the clinical parameters means improvement in the oxygenation, improvement in ability to be mobilized. So all these things need to be considered to decide how long to continue steroid. But if you need to continue for more than 4 weeks, definitely should be very low dose, very low dose.
Right. Anything to add, Dr. Khilani? Is there anything else you wanted to add to the 6 weeks to 3 months?
No.
Anything?
What Dr. Shelly said, I agree with each word. But what I do is that there are no cutoffs which are given. Now, if the oxygen requirement is extremely important. Second important is how the patient is feeling. Feeling of feverish, terribly unwell. If the patient is feeling well, he doesn't require oxygen. If the CRP is 20, I don't worry about it. And I do not continue steroid. Body takes its own action. But if the patient is feeling terribly unwell, he has fever. If the CRP is 25, as Dr. Shelly said, I give him small doses of steroid, which is absolutely unconventional dosages. And tapering has to be individualized. D-dimer, I take it as a marker of inflammation and not as marker of thrombosis. And lymphocyte, lymphopenia also I take it as marker of COVID activity. I combine them all to taper my steroid depending upon if the oxygen requirement is not a parameter, then these are the parameters which are more important. Sometimes it has taken me 60 days to stop steroids.
Sure. Agreed. So there's something very interesting. Another thing that Shelly talked about, which I think is interesting. So I was having a similar conversation with Professor Athelwells a few days ago from the Brompton. And he also said something similar to what he said, which is to do a CTPA in all patients who are hypoxic. So I don't know about your practice, Dr. Khillani, but in my practice, my CTPA is dictated by either a rising D-dimer or an absolute value of D-dimer of above 2000. That's what I have used in my practice. But apparently in the Brompton, they do a CTPA on all patients. I'm not sure whether, again, there's no evidence, but I guess you could go either way with whatever you practice. There is probably going to be supporters for you either way. There's something else I wanted to ask you, and you might have covered this in your case, Dr. Khillani. So almost everyone with severe COVID who's got oxygen requirement gets a CT done. Now you're discharging this patient, maybe discharging the patient with limited mobility on a bit of oxygen. Would you at that point of time do an HRCT on this individual? Or would you actually ask the patient to come back in 6 weeks' time and get a CT done at that point, like you said? And what are the timelines for CT for you? What makes you decide the timelines for CT in these individuals?
So, okay, let's first talk about a person who has had a severe disease. Severe disease means that he was in HDU or ICU. He had oxygen requirement, something like 4 to 6 liters. His CT score was more than around 50. I mean, that's a situation I'm giving. He required oxygen and he's on tapering doses of steroid. And of course, you have done one or two CTs while he was in hospital, for surely, and he's getting discharged. And say for the purpose of discussion, he's getting discharged on the 14th day of admission. And he doesn't have any fever. He's on 1 liter of oxygen. And he's going home and he has had a CT 7 days back while he was in hospital. I do not do his CT at the time of discharge because in my wisdom, it does not help. I've already told you the follow-up of it, and I call them, of course, I do online consults with them every 2 weeks almost on a SOS basis. We are not talking about secondary infections at all. But after 4 to 6 weeks, I do call them. And then in between, I would have done CRPs and all those things. And at 4 to 6 weeks, I've already narrated that I assessed them. And the person who has had a severe disease, like more than 15 of CT score or with hypoxemia, who has been in ICU, surely he will require a CT scan. There's no question. I must comment upon CTPA if what your friend, UK friend said, his threshold for doing CTPA is, my threshold is that if there's unexplained worsening of clinical condition along with D-dimer is a very poor indicator of going for a CTPA in COVID. As I said, in COVID, D-dimer is very frequently raised because of the COVID inflammation. If there is unexplained worsening, then I go for CTPA, and my finding of catching pulmonary embolism has not been very high in COVID patients.
Sure.
It's an experience.
Dr. Khillani, just one quick one-line answer, maybe. So I understand that the raised D-dimer does not have a good predictive value. It never has. What about a low D-dimer? So suppose you had a D-dimer of below 500. Would you actually still think that this patient could have thromboembolic disease?
As I said, if there is my decision to do a CTPA will be based on if there is a sudden increase in oxygen requirement. If the person is breathless, I first do an echocardiogram, D-dimer and ECG, and then take him for CTPA. My threshold is like this because if I was to do CTPA the way you are telling, I would have done thousands of them.
Yeah, sure. So same logic with me. Absolutely. Yeah, completely agreed. A quick point, and then I'll come to Shelly. So my practice is slightly different, and I might as well say this in front of the audience. So if I'm sending a patient home who's had severe disease on oxygen, I would actually do a CT at the time of discharge. I mean, 14th day, 15th day, I would, and my rationale is I would actually start the anti-fibrotic in that case. I mean, I have absolutely no evidence that it works, but I would do it at that point because I would give them the benefit of the anti-fibrotic early if the patient has traction bronchiectasis and or honeycombing. I have to say I've seen very little honeycombing at the time of discharge. I have mainly seen honeycombing later on in a very small percentage of patients. But if they had traction bronchiectasis, definite traction bronchiectasis, I would give them an anti-fibrotic at that point of time. So on that note, I'll go to Shelly quickly, and I'll ask you, Shelly, what makes you prescribe the anti-fibrotic, and what's your choice? What would you actually think of? Where would you do it? And what would you prescribe?
Again, we do not have any evidence. So whatever we have, we do is based on the evidence on other disease. So anti-fibrotics are used mainly in alternative, have been used in wide spectrum of progressive fibrotic lung disease. In inbuilt trial, we know it has been used to wide spectrum of fibrotic lung disease, but those are progressive, mind that. The problem is that in COVID, the fibrosis we all know are regressive, are never progressive, hardly progressive. I have not seen any progressive fibrosis in COVID. I don't know if you have seen or not. But problem with COVID is that what we are worried is that whether we will have any residual fibrosis in long term or not. That's the main problem that we want to reduce, I think, with the use of anti-fibrotic. Now, one thought is that as if you follow the inbuilt trial, then we have to wait for 3 months to see whether it is progressive or not, or whether it is regressing or not. And then we have to decide whether to use anti-fibrotic or not. So that is one thought. Most of the physicians or institute actually believe on this, but I have the same belief as you, Dr. Rajada, to start anti-fibrotic early in 3rd week or maybe 4th week, because you see the pathogenesis or the changes that we see in COVID mostly occurs in initial 2 or 3 weeks. There is sudden changes in the CT scan. You see the fibrotic changes, and it peaks at 3rd week or 4th week, then gradually it regresses. So if there is any fibrotic pathway is active, I think it is mostly active in those periods, initial that 3rd week or 4th week. After that, it regresses. So that's why if you have to gain from using anti-fibrotic, you should use it early on 2nd week, 3rd week, or 4th week, rather than going to the 3rd month or later on. And again, if you see the ongoing trials, the Boehringer is using already having ongoing trials, 2 trials they are using, and they are trying to assess whether the anti-fibrotic alternative is effective on 2 group of patients. One where they are using it early on 4th week, if there is any changes, persistent changes, and another they are using it 2 months to 12 months. So I think these 2 trials will give us the answer whether when to use. But my take is that if you have to use fibrotic, it is better to be used on 3rd week or maybe 4th week. If we see any fibrotic change or residual change.
I'll come to you, Dr. Khilani. I'll come to you. I know you want to speak. I'll come to you. I've got a couple of questions for you also. Along with what Shelly said, my rationale was, if you look at Impulsis trial, the separation between the 2 curves, the placebo and the nintedanib, actually happens early. It happens
4 to 6 weeks.
Yeah, so it happens at 2 weeks. The separation starts, it peaks at 4 weeks.
Exactly.
Produces exacerbation. So that's my logic. I understand, Dr. Khilani, if the disease is regressing anyway, why would you give them an anti-fibrotic in the first place? So I understand your rationale, but your point about this first, and then whenever you give an anti-fibrotics, even if it's at 6 weeks, your choice of anti-fibrotic and how long would you give it for?
So I have to make my point. So sorry, I have to go back to what I want to say is I'm grossly misunderstood. Like this case was there where I did not give anti-fibrotic.
Sure.
Large score. This case was there. Is actually father of our nephrologist, and anybody can say that fibrosis is setting in. But I did not believe that. I didn't give him steroids. Over a period of 2.5 months, it has got cleared. Now, this is a case. This is a 1 month apart. This is a case where at the outset, while the patient was in hospital, I saw fibrosis. And you can see the CT findings of fibrosis. There's already traction bronchiectasis setting in. And you can see this traction bronchiectasis, and I've enlarged it here. Here I didn't wait.
Okay.
I didn't wait here. So,
Right.
So other thing I want to say that we must understand, what does anti-fibrotic do in IPF? They don't cure fibrosis.
Sure.
They reduce the decline in lung function. They don't improve the fibrosis. So therefore, my thinking is if you are documenting inflammation, then treat it with steroids. When the fibrosis, you see the fibrosis is setting in. This patient has not improved with antifibrotics. No. He improved with steroids. When I gave him antifibrotic, he's continuing with the antifibrotic. Nobody's oxygenation improves with nintedanib or pirfenidone, to my mind. What you are trying to do is reduce the decline in lung function with antifibrotic. So if the inflammation is documented, please put your money on anti-inflammatory. If the fibrosis is set in, try to reduce the fibrosis by try. We don't know what happens. So that's my take, and I should have, and I want to, through you, tell me like this is, anybody would say that fibrosis is setting in this. You can see beautiful lobules, thickening. But this patient completely reversed. This is organizing pneumonia. But if I see this kind of CT, I'm not going to wait. Sorry, I had to come back again.
No, completely agreed, Dr. Khilani. I think so. We all agree if there's traction bronchiectasis at the time of discharge, we would prescribe an antifibrotic. So that point is well taken. Choice of antifibrotic and for how long, Dr. Khilani?
You are making your question more difficult. My choice so far has been nintedanib over pirfenidone for the simple reason of that census trial, in which it has been tried in non-IF interstitial lung disease, be it scleroderma or other fibrotic lung disease. Second is ease of administration. And third is my personal experience that I find my patients, they easily tolerate nintedanib. The diarrhea has not been as common as reported at 60 to 65% in the Western literature. In very moribund and elder patient, I give 100 milligram, start with, and bring it to 200 milligram. I don't escalate beyond that. And otherwise, the usual dose of 150 milligram twice a day. But I have no way of saying that which one is better, pirfenidone or nintedanib.
Sure.
Now, the duration, you have to tell patient for how long. There are, of course, as Dr. Shelly said, there are no trials and we have to wait for the trials. But it may be quackery, but I tell them when I start nintedanib, I tell them that at least you have to take it for 6 months, maybe 1 year. This is because in 6 months, I expect some answers from the literature so that I'll be able to tell them. By then, I would also know whether they are responding to the treatment or they are not. Thank you.
Grand, thank you. Just one more point I want to add, and maybe if you can sort of nod your head in agreement if you agree, Dr. Khilani, is about patients who are going home on a novel oral anticoagulant, so something like an apixaban, which quite a few patients do depending on how severe the disease is and what the D-dimer is at the time of discharge. I would actually give them pirfenidone because of the supposed interaction between the NOAC, apixaban, and the nintedanib and the increased risk of bleeding in these individuals. So that's the only place I would actually prescribe pirfenidone if I had to prescribe an antifibrotic in these patients.
So I'll nod my head for you, saying yes, but with a rider. With a rider, the thing is that as far as the oral anticoagulants are concerned, the usual recommendation is that you give anticoagulation for about 2 weeks after discharge. And there is no evidence in the literature that these anticoagulants lead to better outcome as far as the lung is concerned. As I said, that if you are treating D-dimer is a indicator of inflammation. So very occasionally one has to combine, in my practice, anticoagulation with antifibrotic. Usually I am done with anticoagulation when I start with the antifibrotic. Under your pressure, I went through the literature on this. Since you have posed this question to me, there are no answers to this in the literature, whether nintedanib and apixaban or rivaroxaban, even given together, causes more bleeding, especially in relation to COVID. In the Impulses trial, there is some evidence of increased bleeding. Thank you.
Thank you. So Shelly, we are sort of coming to the end. Last 10 minutes, we want to take some audience questions also. Dr. Khilani has spoken about this, but your take, the regime about doing a spirometry, a DLCO, and a 6-minute walk. So Dr. Khilani spoke about 6 weeks, but going forward in patients who have residual fibrosis, how would you monitor these patients? When would you bring them back? And what would you do with monitoring these tests on a long-term basis?
What I do, I told all these things are important in severe group of disease, because moderate disease we wouldn't be that much conscious or cautious in monitoring in long term. But in severe disease, I told I usually do CT scan. If not improving, then so initial evaluation at the 3rd week or 4th week is there, this scan. Other second scan or maybe this physiological monitoring, usually I defer looking at the improvement of the patient. If the patient is gradually improving, then I would not touch up to a 2 or 3 months. After 3 months, maybe 12 weeks or maybe 10 weeks or something like that, then if the patient is still symptomatic, I would go for these physiological tests, because in between, if the patient is improving, then doing a PFT or maybe DLCO, I know there will be some sort of reduction in those values. You know what extra I should do. So after 3 months, I would try to assess, and if required, I may again repeat CT scan. So that's my take after 3 months.
Okay. So I think we are giving slightly different messages here. So I'll also give my message. So somewhere between, so I probably would do an FVC, a DLCO, and a 6-minute walk at 6 weeks in most patients with severe disease who've required some amount of oxygen during their hospital stay. So 6 weeks to 12 weeks is what we are saying is the time when you do lung physiology testing. So FVC, 6-minute walk, and DLCO, at between those 6 to 12 weeks is when you do it. And then you repeat it depending on requirement, but definitely again at 8 to 12 weeks after doing the initial test. I think that's how you would follow these patients up in the long term till the values come back to normalcy, or you might actually need to follow these patients up on a long-term basis. I'll stay with you, Shelly, if you can give me a short answer. You said about CTPA and the fact that you do probably more CTPAs as compared to what we do. Now, what's your experience about finding clots in these patients? What is your regime for giving these patients anticoagulation in the long term, depending on whether you're sending them home on with the suspicion of a PE or established PE? How do you actually work your way around treating these patients in the long term?
Again, routinely CTPA, it is not definitely not done. I told that in severe group of disease, patient is not improving, then I would do. Oh. Other than that, I would go for CTPA if there is high D-dimer, obviously. Although D-dimer may be high because of inflammation, but if it is really high, more than 2000 or 3000 or something like that, it increases the probability of having PE. If this hypoxia is still persisting, then I would go for CTPA. If we have established PE, okay, fine, then the protocol is as per PE. We have to continue with the anticoagulant as per the regime of pulmonary embolism. That's established regime. Oh. If you do not have PE, then whether to use anticoagulant, prophylactic anticoagulant, I would say, after discharge. I think that would be the more pertinent question in COVID. Now, question is, if there is no PE, the evidence suggests that after discharge, although we see that the news of having embolism post-discharge, but if you see the studies, the incidence of P is not that high. It is hardly, I have gone through the literature, it is 0 to 0.6% in 3 months. Not that high. In COVID, altogether, mild, moderate to severe group they have included. And this group, if they are followed up, and hardly 0 to 0.6% cases they had pulmonary embolism on follow-up. So that's why, and also the same thing is recommended by different academic bodies, that we shouldn't routinely use prophylaxis after discharge. Only we should consider prophylaxis if there is definite criteria which is true for other diseases also, that criteria is modified, improved VT risk score. That includes several points, several risk factor for future follow-up thrombosis. And if this criteria is fulfilled, and that includes, I would say, which is important for COVID, is that if the COVID is patients are there in ICU for a long period, and if there is D dimer more than one, they have the cutoff of 2 times of upper limit of D dimer. That means more than one. And along with that, if there is immobility, means we are sending the patient when they are not mobilized properly, and those cases, I think we should use the combination of them: immobilized patient, D dimer more than one, and along with ICU stay. Then we should use a prophylactic anticoagulation long term, maybe up to a month.
Sure. And the evidence, like you said, Shelly, so completely agreed with you on all points. So the regime that's been looked at in most trials is apixaban at 2.5 milligram twice a day. And it's for 2 weeks in most cases, even though some studies have said 2 weeks to 6 weeks. But I would go more in favor of doing it for 2 weeks rather than 6. So one last question, Dr. Khilani, I'll come back to you. This is about airways disease and COVID. So 2 different scenarios: someone who's never had allergic disease, never had asthma, had a lot of dry cough during the disease process, goes home with cough. And the second scenario is someone who's got pre-existing asthma, gets COVID, and again has cough and wheezing and goes home. What do you do with these patients? Is it just inhaled corticosteroids you give them if you give them this drug, or is it a combination of a LABA and an ICS? And how would you follow them up? So airways disease and COVID is my question.
So the thing is that post-viral cough, as it is common in other viral disease, it is equal or more common with COVID. So if I talk about mild and moderate diseases, which sometimes require admission, sometimes may not require admission, after the COVID, after 14 days, they become negative or whatever, and then they come back with, somehow they have a very peculiar kind of chest discomfort and tightness. And it is usually retroexternal. It is not a pleuritic pain, but they have some difficulty, and then they also complaining of some irritation in the throat, which is very irritating to them. And they have cough, which may not be very troubling. There is no wheezing, there is no shortness of breath. I am giving you a clinical scenario. You examine them, they do not have any wheezes or crepitation. The X-rays doesn't show anything. Generally, I don't subject them to PFT, but sometimes if there is a nocturnal sitting, when I do the PFT, there is no airway obstruction that I see. Occasionally, whenever I do, these patients, I do not have anything convincing to offer to say that they will respond to this. So I do give them inhaled corticosteroids with or without bronchodilators. It depends upon case to case, because I myself don't know whether the bronchodilators would help, because airway inflammation with little bit of bronchospasm, neither our stethoscope nor the spirometry picks it up. I do all them cough syrup. They are very fond of taking steam, which I think does not help in this airway inflammation. That is about cough in patients who do not have any pre-existing airway disease. Now the second part is, then I poke them with the question: did you have seasonal cough? Did you have seasonal rhinitis? 40% of the population have allergic rhinitis, that we know. If that is so, then I assess them more closely and do a PFT for them. There may be airway obstruction, there may not be airway obstruction. If there is airway obstruction, the job is easier for me. If they have nasal symptoms concomitantly, then I have no hesitation in putting them in montelukast and fexofenadine or levocetirizine, whatever combination. Along with this, depending upon the severity of spasm, I put them on ICS LABA combination, whether it is by inhaler or whatever form. Cough syrups have very little value in this. And again, the steam doesn't help at all. But if they want to take, if somebody asks me, shall I take steam? I said, take steam and see whether it helps you. Some people will have reflex cough after the steam. And assure them that, and then sometimes they are very fond of knowing what to eat, what not to eat. Dahi din mein khani hai, raat mein khani hai, chawal khana hai, nahi khana hai. But actually, we pulmonologists know that it will take its time, and it is not much of consequence. But we have to be aware that sometimes these patients might have mediastinitis or mediastin. All those things have to be kept in mind,
Sure.
and never to forget in a patient who is 40 plus or hypertensive or diabetic, that CAD also and myocarditis is also can occur on even ischemic episodes can also occur. Those things will have to be kept. Thank you.
Grand. Thank you. Thank you, Dr. Khilani. We'll finish in 5 minutes. We are run over by about 5 minutes already. Finish in 5 minutes. Couple of questions. So I'll answer one question to start with. So there's a lot of questions in the question box which talks about giving steroids and the risk of mucormycosis. So I've got two perspectives, and please do add in Shelly and Dr. Khilani. So the first is that mucormycosis or any other superadded infection is the risk if you actually prescribe the steroid unindicated or in higher doses as compared to what is recommended, something which was stressed upon by both Shelly and Dr. Khilani during when they spoke. So I think that's important. We have seen people having steroids at day 1 or day 2 of onset of fever. We've had so many patients who have actually seen us after taking steroids for 5 days. It's been started as the first drug. And we have seen so many patients with severe COVID who've actually had pulse steroids for long duration, very high doses of steroids for long duration, who've had more of mucormycosis. In recommended doses, in the doses our esteemed panelists spoke about, the risk of secondary infection is not huge. And we've used these doses in other indications for a very long time. So I wouldn't fear about mucormycosis in those individuals. I would fear about it when you're giving it unindicated or in too high doses. There's another question. I'll take that to Dr. Khilani. Dr. Khilani, there's a lot of concern, it seems, about giving nintedanib to people and adverse effects. So I think you spoke about this. I have actually found nintedanib to be a very safe drug, not just in post-COVID, but also in patients with IPF and PF-ILD when I've given it to our patients. I think it's better tolerated in Asians as compared to what Europeans report about diarrhea in their population. Your take, Dr. Khilani?
So first I will spend 30 seconds on mucormycosis and fungal infection. I came across a paper where 706 autopsies were done in COVID patients. And they found fungus in 2%, only 2%. Obviously, they were severe cases. And out of 700 cases, there was only one case of questionable mucormycosis, questionable. So that was actually eye opener for me. That only underscores what you said. Sure. That if you don't use steroid indiscriminately or else you monitor the sugars properly, give insulin, then there's no reason that black fungus or other fungal infection would occur in this. And if there are some unknown factors, we really do not know. Now tell me, what was your question? Sorry, I was focused on.
Not at all. My question was about safety of nintedanib. I said I found it to be a safe drug. There's a lot of
so that's
the question box.
Yeah. Okay, let me also tell you something, Raja. Longevity, if we talk about longevity, we have more experience with pirfenidone for the simple reason that pirfenidone came earlier to India, that is one. And when the nintedanib came, the cost was 65,000 rupees per month, which working at All India Institute of Medical Sciences, almost 100% of my patients could not afford. So I had to depend on pirfenidone for that reason. And I was very rarely was able to reach the dose of 2,403 milligram as, at 1,200 milligram, they start complaining of severe unwellness and gastritis and liver derangement. I didn't see, but they somehow became very unwell. So till that time, I did not have much experience of nintedanib because affordability was a problem. With the COVID, as I started using, and I started telling patients, look, there is 60% chance of diarrhea, but I didn't see any diarrhea. Actually, almost. And if the diarrhea was there, it was very little, that we didn't have to actually stop. Only in one case, I remember that I said, okay, since it is a recommendation, stop nintedanib and put him on pirfenidone. Otherwise, even the LFT derangements as per the literature are uncommon, and I also, so whatever little experience I have in post-COVID patient after the second wave and after the first wave, nintedanib is very well tolerated. Only thing I'm scared, so I said in the elderly 80 plus or something, I give 100 milligram. Otherwise, I give full dosages, and generally I give for first 7 days I give 1 tablet and then escalate it to 2 tablets so that they tolerate it well. Besides that, I have not seen any other adverse effects. But one thing,
Yeah.
sometimes they start feeling unwell after nintedanib. And this is anecdotal, but their mouth become very sour and their taste, they don't say we don't like our food so much. This is I have noticed but not read about it. But LFT is not deranged. At best, instead of with the 40 of the upper limit SGOT, it goes to 50, 60, where I don't have to stop. Thank you.
Thank you very much. So that's reassuring that I share Dr. Khillani's experience. I think it's a very safe drug. I'll come to you, Shelly, the last question. Very clever question, actually. So this talks about use of positive pressure, be that with non-invasive ventilation, be that with high flow nasal oxygen, or be that with invasive mechanical ventilation, and promoting fibrosis, so causing lung injury by positive pressure. Do you think this is an important factor? Would you sort of take this into consideration when you treat these severe COVID patients?
It is well established. It is well established that positive pressure actually promote fibrosis. It is true also in ARDS. We know that barotrauma after giving ventilator that can actually promote fibrosis in ARDS also. So that's why it is really true. Whatever positive pressure we use, maybe with NIV or maybe ventilator, can actually aggravate the fibrotic part. Should be cautious enough, if not required, should keep the pressure to the limit. But definitely we have to use it to treat. So it's a definitely risk.
Sure.
Can I add something?
Yeah, of course, please, Dr. Khillani.
So, in patients who are with acute lung injury, as I was growing in critical care, I read about, I came across volute trauma. Volute trauma is because of giving high tidal volume with the positive pressure, which leads to liberation of cytokines, which itself causes ALI or acute lung injury. Now in COVID, it becomes more important. When you give non-invasive ventilation, especially, you give pressure cycle ventilation. Means that you give pressure like 12/6 or 18/6. The volume is not controlled. Now we know that the first part of the ARDS has a high compliance ARDS in COVID, as Gattinoni has suggested. And when we started giving NIV by the conventional ventilator, we realized that even with, say, 14 and 6 pressure, sometimes the tidal volume were going up to 600. So there are one that it causes inflammation, and inflammation is forerunner of fibrosis. So it stands to reason it will cause fibrosis. Equal or more important is pneumomediastinum and pneumothorax, which is very common with COVID. We do not know why, but it is extremely common. Sometimes even without putting them on any kind of positive pressure, there are large mediastinum and pneumothorax. Sometimes bilateral. We have seen that if you give a high tidal volume by BiPAP, because you have no control on the volume generally, then there's an enhanced risk of pneumomediastinum and pneumothorax. Thank you.
Sure. So, Dr. Khillani, we've experienced that too, and it seems to have been much more in the second wave as compared to the first. I'm not
absolutely.
Yeah, but it seems to be very common. And so, audience, when you see these patients suddenly desaturating, along with the PE, along with the COVID myocarditis and heart failure, secondary infection, think pneumothorax, think pneumomediastinum, because that's something where you can help the patient by putting in a small pigtail catheter and getting the lung to expand again. I think that's an important message. A one-line message from Shelly and a one-line message from Dr. Khilani before I conclude. Shelly, what's your one take-home message to the audience about post-COVID lung fibrosis or post-COVID pulmonary complications before we call it a day today?
Initially, we may be frightened with the clinical picture or maybe CT radiological picture, but we have to take time. So time is the factor. We need to wait. We need to use our medicines judiciously, shouldn't harm the patient, and we need to wait, assure the patient, mobilize them. With time, definitely you'll see the patient will improve and will win the the message.
Thank you, Shelly. Dr. Khilani, please.
I would very strongly urge that they don't have a low threshold for starting anti-fibrotic drugs, because one, that they definitely compromise the quality of life because of the adverse effects. That is one. Second, we do not know the actually positive effect of these drugs on the progress of the disease. Certainly, they do not improve on the symptoms. So, whatever we have talked today, I think 50% we have talked about when to start anti-fibrotics. The request is, if you agree with us, please follow that. Thank you.
Thank you very much, Dr. Khilani, and thank you very much, Dr. Khilani. I'm really grateful. You never say no to any of my requests, and I keep bothering you. So really,
I take it as an order.
Thank you, boss. And Shelly, thank you very much. Absolutely enjoyed this discussion with you. I would like to thank the Association of Chest Physicians of West Bengal. Somnath, if you could kindly put your camera on, please. A big thank you to my dear friend, Somnath, who is now heading the ACP, to Dr. Urunapad Datta Chaudhary, who's always with us in doing these ACP programs, and all the delegates from ACP and outside who've attended this program today. A big thank you to all of you. And again, a big thank you to Lupin, Abhijit. Thank you very much to the entire team and yourself. Thank you very much for being there for the ACP. Somnath, anything else you want to add as a last line, Somnath, from a perspective, or shall we call it a day? Okay. So thank you very much, everyone. Adieu. Thank you. Thank you.
Good night. Good night.
Bye-bye. Thanks.
Thank you so much, sir. Good night.
Thank you, Abhijit. Thank you.